and the very generous introduction. And I'd like to also say it's really an honor to talk about this topic, and it's also a very timely presentation in view of some of the very new and exciting medications that are available for GIST patients and new technologies. And if you don't have the time to or the opportunity to ask a question, feel free to email me at the email address, or send me a direct message through Twitter, or follow me on Twitter, and it's on my front slide. And we'll get started discussing a little bit of background. I'm sure it's a mixed audience, and so we'll get started. I think we'll get started. Okay. Somehow my computer is not advancing the slides. Hold on one second. I'm just having some technical difficulty. Okay, so we're talking about GIST today, but the reality of most of us that manage GIST patients, we take care of a variety of different sarcoma types. And this slide is really to remind us that there are a lot of different types of sarcomas, of which GIST is one of the types. GIST is actually one of the more common types of sarcoma. But this slide also reminds us that GIST is a unique type of cancer. There's not one type of sarcoma. There's literally at least 70, if you go to the textbooks, over 200 different types of unique cancers that fall under the diagnosis of sarcoma. GIST is actually the most common GI sarcoma by far. It's about 0.2% of all GI tumors, about 80% of all GI sarcomas. It's distinct. It is a distinct entity from other sarcomas and has an incidence around the age of 50, similar male to female, and there's somewhere between 3,000 to 5,000 newly diagnosed GIST patients per year in the United States. The clinical presentation is highly variable. GIST can arise anywhere in the GI tract, from the esophagus all the way to the rectum, and that initial site where the GIST forms may drive the diagnosis. For instance, if a patient has a GIST in the esophagus, the first symptom they notice might be difficulty swallowing. There is, unfortunately, a high recurrence rate after surgery. If you look at all GIST patients combined, the probability of recurrence after surgical resection of a tumor with negative CAT scan is about 50%. And historically, prior to the advent of targeted therapy, there were no effective chemotherapies. These are the chemotherapies that were tried in GIST patients pre-2000, and none of them were ever showed really any significant activity. Pre-2000, many centers called GIST GI leiomyosarcoma, and so some of these patients were probably real leiomyosarcomas and could explain the occasional response. But there's really no role today for chemotherapy for patients with GIST. GIST is also unique in several different ways. Other than being rare, it's unique in that it is a molecularly driven disease. The most common mutation in a GIST patient's tumor is in a gene called KIT. Most commonly within KIT, that mutation takes place in a location called exon 11. Well, there's other locations where these mutations can occur, such as exon 9, 13, 17. But most common are 11 and 9 within the KIT gene. As I'm going to discuss later, there are other genes than KIT where these mutations can occur. So what happens when there is a mutation in the DNA of a normal cell in the GI tract, which we think is the interstitial cell of Cajal? And so this DNA mutation turns that normal cell into a cancer cell. And it does that by driving all of these processes on the left side of the screen: proliferation, survival, adhesion, invasion, metastasis, angiogenesis. Next thing you know, that normal cell becomes a cancer cell, and it splits from 1 into 2, 2 into 4, 8, 16, 32, 64. Next thing you know, you have a big tumor that then acquires the ability to spread to other organs, such as the liver, namely. And this is all driven by this mutation in a gene called KIT. Now, work took place in laboratories with other diseases such as CML, and a series of molecules or drugs were actually developed to block these receptors like KIT. And if you look at the right side of this screen, you'll see a cartoon depicting Imatinib that binds to the KIT receptor and turns it off, just like turning off a light switch. And this blocks all those bad things that tumor cells do, such as proliferation, survival, etc. And Imatinib binds at these specific points, and these points are where it's able to lock onto and shut down the receptor, and the tumor cells not only quit dividing, but they actively die. And this really led to one of the first studies, and this is the first large studies where patients with metastatic GIST, meaning it had spread to another organ, were enrolled in this clinical trial and randomized to either 400 or 800 milligrams. This trial took place in the North America group, but it also took place in Australia, a European trial that was actually larger. Patients were allowed to cross over to higher dose and were followed for survival. And this showed great results. If you look at this Kaplan-Meier analysis, what you see are curves, 3 curves. The red and the blue are essentially the same. Green is clearly different. And each downward deflection in the curve is a point at which the GIST has taken the patient's life in terms of times across the bottom. And so on average, a patient with metastatic GIST prior to 2000 had about a 9-month average survival. If you look today at more contemporary data, the average survival is about 7 years. And I suspect as we're catching GIST earlier and have better medications and newer medications, that number is just going to continue to increase and increase. So one question has always comes up when I see patients in clinic, and this common question is, how long do I take my Imatinib or my Sunitinib or Regorafenib or any of the other newer medicines, Ripretinib, Avapritinib? And so how long do I take these? My tumor has shrunk some. I'm doing great. I feel a lot better. How long do I take it? And so in France, Dr. Blay et al. Did a study where patients who responded or had stable disease for 3 years were randomized to either continuing Imatinib or stopping Imatinib. And at the most recent presentation of the data, in this curve, what you can see in the white writing up by the green line is that if a patient continues to take Imatinib, at 1 year, almost 90% are progression-free. After 3 years of Imatinib for metastatic GIST, if a patient discontinues, on the orange curve, about 75% of the patients have progressed, or only 25% are progression-free. So what this tells us is that most patients benefit by continuing with metastatic GIST. Most patients benefit from continuing their Imatinib, although they may take holidays occasionally for certain reasons. Continuous therapy is generally recommended because we know the tumors will start growing again with a pretty high certainty if we discontinue. So the next drug that was developed to treat patients with metastatic GIST was Sunitinib. And so Sunitinib was studied in this randomized trial where patients received either Sunitinib or a placebo. And what we found was that if a patient was randomized to the Sunitinib arm, they had on average about a 6-month period before their tumor started growing again. Now, certainly this is an average or a median, actually, but many patients stayed on Sutent longer. Some patients stayed on it shorter, but the placebo patients did very poorly. That's why we discourage placebos in most trials when it's really possible to do it. And after sunitinib was developed, regorafenib is the third agent that has been developed to help us treat patients with metastatic GIST. And you can see from this study, the median overall median progression-free survival is about 5 months in the study, a little shorter than sunitinib, but still many patients benefited from this therapy. And so when a patient responds to any of these medicines, we get regression of tumor, we might get shrinkage, we might get a situation where the tumor becomes necrotic and dies from the inside and turns darker on a CAT scan or stops showing up on a PET scan. And patients can do well for sometimes many years on any of these medications. But at some point, the GIST often starts growing again. When it does start growing, we call that progression. Progression can take a couple of different forms, so it can appear differently to us. And this is somewhat of a new paradigm in solid tumor oncology in general, but it's very part of our everyday life, and just to be able to recognize these different types of progression. So one type of progression could be limited or nodular, and what that means is that, for instance, a patient may have 3 lesions in the liver or 5 lesions, but only one of them is growing. And if that's the case, we may be able to attack that one tumor that's growing and continue the medicine that has been helping the other 4 tumors. Doesn't make sense to stop the medicine because it's controlling 4 of the tumors, but only one of them is growing. So we do sometimes attack single tumors or a limited number of tumors using what we call a localized therapy. So this is a therapy directed at a solitary nodule in the abdomen or in the liver. And there are several different approaches, and every patient's different, and we have to really individualize on case by case which one of these approaches is best for the patient. One approach is called hepatic arterial embolization, where a catheter is placed into the artery that's feeding the tumor, and it's sealed off with foam particles, and then the tumor doesn't get the necessary oxygen or nutrients to survive and dies. Another one is called hepatic radiofrequency ablation, and that's where a needle is placed in the tumor and ablated with radio waves. This could also be microwaves or electrical waves or cryotherapy. There's different ways to ablate or kill nodular tumors. Certainly surgical resection is a possibility. If there's only one lesion in the liver that's growing or abdomen, then we may be able to use therapy. Particularly for esophageal or rectal tumors, we know that we can deliver high enough doses of radiation to kill GIST cells. Radiation therapy is not a everyday or common modality of therapy in GIST patients because in the abdomen, the intestines, the large and small intestine, can only tolerate low doses of radiation. However, if the tumor's in the pelvis, or if it's a metastatic site in the liver or even in the bone, then radiation therapy really is an option because higher doses of radiation can be given safely. And so that's really for what we call limited progression in localized areas. Now, the other type of progression we call widespread progression, and that's where multiple nodules throughout the liver, throughout the body, are all enlarging at the same time, and there's really no way to use a localized surgery to treat all of them. And so then we have to lean towards systemic therapies such as increasing the dose of Imatinib, switching to sunitinib, switching to Regorafenib, or looking at a clinical trial, of which there are a number that are very exciting right now, such as Avapritinib and Ripretinib. So it's just an example of a patient of mine who had hepatic arterial embolization. So the patient had several lesions in the liver, was on imatinib, but only one lesion was growing. And if you look on the left panel at the red arrow, you'll see a liver that has a lesion in it, and it was growing fairly rapidly. But the other lesions were not. They were still necrotic and dead. So we didn't think it made sense to switch to sunitinib or another medicine, because then the lesions that were being controlled by imatinib might start growing. So instead, what we did was worked with my colleagues in interventional radiology, and they were able to put a catheter into the artery feeding the tumor and choke off its blood supply very successfully. And now on the right panel, you can see that the tumor is now darker, it's necrotic. The darker are the necrotic dead areas. And so it looks a whole lot better on the right. And so what about surgery in GIST patients? I'm not a surgeon, but these are some of the principles that my surgical colleagues here at Sylvester really follow. We really prefer endoscopic biopsy for a primary tumor, because a percutaneous biopsy through the skin into the tumor could rupture it, it could cause hemorrhage, it could spill tumor cells into the abdomen. So whenever it's possible, we do the biopsy through a scope so that the biopsy does not spread tumor cells within the abdomen or in other sites. Negative margins are generally the goal for any type of cancer surgery, and our surgeons confirm that by having a pathologist right there in the operating room who takes a look at the tissue that's resected. These tumors are friable sometimes, meaning that they can fall apart. The capsule can rupture. Tumor rupture is really an emergency in GIST. We try to avoid it at all costs. So sometimes with larger tumors or friable looking tumors, we do use preoperative imatinib therapy to try to kill tumor cells, to try to enhance the ability to perform organ-sparing surgery, as well as to minimize the probability of tumor rupture. GISTs are usually lymph node negative, so extensive lymph node dissections are not really standard surgical procedure. Resection is usually not performed if there's a few microscopic cells left at the border. The recurrence rate is actually still very low in that situation. So most surgeons will opt to treat with imatinib or follow very closely for when the microscopic margins are positive. So I mentioned that after surgical resection of all comers, when a GIST is removed and there's no metastatic sites by any type of CAT scan, PET scan, surgeon didn't see any disease when they operated other than the primary tumor, it's about 50% recurrence rate at 5 years. So we need to do better than that. And so imatinib has been studied in a series of clinical trials looking at 0 versus 1 year after surgery, 1 versus 3 years after surgery, and now an ongoing study in Europe of 3 versus 5 years. This is data from the 1 versus 3 years. So all of the patients on the study had their GIST surgically resected and had no evidence of any GIST anywhere in their body. They were randomized to either 3 years or 1 year of imatinib therapy. And if you look on this table in the red box, I highlighted 5-year overall survival. And if a patient after surgery takes imatinib, 92% are alive at 5 years if they took imatinib for 3 years. If they took imatinib for only 1 year, it's 82% of patients that are alive. Above the red box is recurrence-free survival. It's about 20% better recurrence-free survival, meaning 20% more patients will be alive without a recurrence if they take imatinib for 3 years versus 1 year. So this is generally our recommendation in our practice when we see our GIST patients here at Sylvester, and that is to, for a subset of GIST patients who we think are at high risk for recurrence, these patients are treated with 3 years of adjuvant imatinib therapy. The way we typically define high risk for recurrence is when a tumor is large, meaning bigger than 10 centimeters, or a tumor is aggressive with a high mitotic rate greater than 10 centimeters, 10 mitoses per 50 high power field, or when a patient has a combination of greater than 5 centimeter and greater than or equal to 5 mitoses per 50 high power fields. So those 3 categories, most GIST specialists agree to have a discussion about taking imatinib for 3 years. If it's smaller or fewer mitoses, then you can still have the discussion, but there's less data to support the use of imatinib after surgery. But in some situations, there are factors that increase the risk that we do consider and do use adjuvant imatinib after surgery. So what happens when imatinib stops working? Well, in some areas around the world, there are agents that do have activity against GIST, and when imatinib, sunitinib, regorafenib are not available, we may take advantage of some of these agents that are KIT inhibitors, are PDGF receptor inhibitors, and they might be able to slow tumors down, or they might be able to decrease the growth rate of tumors. They may even be able to shrink a GIST sometimes. But these are not approved in the US by FDA. There's no guarantee that we can get these agents. We try sometimes. Sometimes we can get them, sometimes we can't. But it's an option for certain GIST patients. So I'd like to go into a little more detail about the GIST subtypes. There, as we know, and as I showed you at the beginning, there are literally over almost 200 different types of sarcoma. There's at least 70 different types that we see pretty commonly. One of those types is GIST. Well, as we are moving forward in biology and in clinical research, we're really understanding that there's just not one type of GIST. There's several types of GIST. And so on this slide, I'd like to show some of the different types of GIST. We know that KIT mutated GIST is the most common type of GIST, usually exon 11 or exon 9. But we also know that when tumors become resistant to tyrosine kinase inhibitors, such as imatinib, sunitinib, regorafenib, they can acquire new mutations. Largely, resistance mutations occur in exon 13 or 17. But there's other genes outside of KIT, such as PDGFR, platelet-derived growth factor receptor alpha, mutant GIST. Now, some of these mutations are sensitive to the regular kinase inhibitors, such as imatinib, sunitinib, regorafenib, but the D842V mutation is resistant to everything that has been studied against this disease until very recently. Our work at the NCI has led to studying what has been called wild-type GIST, pediatric GIST. Now we know that when no mutations are identified in a tumor, we always look for immunohistochemical expression for a protein called SDH, or succinate dehydrogenase. Now, when this protein is lost, that leads to a switch that switches from leads to a switch in biology and triggers epigenetic changes that can lead to turning that normal cell into a cancer cell. So now there's a type of GIST called SDH deficient, which can be due to deletion of a gene or can be due to silencing of a gene through some other mechanisms. But it's a distinct entity, and yes, there are subset that are younger or pediatric with this type of GIST. We also found mutations in other genes such as RAF, NF1, PI3 kinase. There's some thought about insulin-like growth factor overexpression. And there's lately been several GIST patients with a fusion in a gene called trk, which has really been recently described. So I'll just show you examples about why this is important. This isn't just nomenclature, this really applies to us in the clinic. And so this is data from the MetaGIST study that was published a number of years ago, looking at overall survival. And this took patients from the study, the initial phase 3 study. About 1,700 GIST patients were randomized to either 400 or 800. If you look at the orange and the yellow curves, you don't see any difference. They're completely overlapping. That's other exons, 11 mostly, but also other exons. And so it doesn't really matter if an exon 11 mutant GIST patient starts with 400 milligrams or starts with 800 milligrams, the outcome is the same. But if you look at the dark blue and the light blue, there's a separation in those two curves. And that separation is because the light blue patients did a lot better. And they did a lot better because they're exon 9 patients that were treated with 800 milligram dose, whereas the dark blue line patients were treated with a 400 milligram dose and did about 10 to 15% worse overall. So patients do better when treated with 800 milligrams as their initial dose if they have a KIT exon 9 mutant GIST. So what we do in our practice when we do have this data, then we don't start at 800. We typically start at 400 and slowly escalate to 800 milligrams or 600 milligrams or the highest dose that the patient can tolerate with a reasonably good quality of life. But this is overall survival data, so I think it's critical to know this information. Here's a patient of mine with KIT exon 9 mutant GIST, was initially treated with 400 milligrams of imatinib, but the tumor grew very rapidly in a viable sort of way from the far left panel to the middle panel. And then at the middle panel, we changed her dose to 800 milligrams. And you can see that this patient's tumor stayed about the same size, but what you notice is that it got smaller on the far right edge of the right panel, and the tumor in the right side of the patient, right next to that red arrow, became homogeneous and dark. So this is a sign of necrosis and death within the tumor, simply because of escalating the dose a little bit. Now here's a patient with a GIST in the abdomen, and this is in the yellow circle, and this patient's tumor shrank on the right. Well, previously the patient was treated elsewhere with imatinib, and the tumor continued to grow. And that's because this patient's tumor doesn't have a KIT mutation, but instead has a RAF mutation. RAF mutations can be treated by RAF inhibitors. In this instance, Regorafenbi is a potent RAF inhibitor, is available for GIST patients that have this mutation type and can induce regression of tumor cell death, and better outcomes clearly than using a KIT inhibitor that would not target RAF. So here's a patient prior to 2017, and with the purple arrow, you'll notice a small lesion that increases from left to right. And that's increased when the patient was on a tyrosine kinase inhibitor clinical trial. And that's because prior to 2017, there really were no very limited options for patients with a PDGFR D842V mutated GIST. This mutation was resistant to all of the known medications, kinase inhibitors. So what came out around 2017 is a medicine called Blue 285. Now it's called Ripretinib, and it was designed for GIST patients. It was designed to be active at the D842V locus. That's the exon 17, exon 18 end of the tumor. And so in PDGFR alpha D842V, on these CAT scans, you can see in the yellow oval, you can see a tumor decreasing in size on this medicine. This has never happened before with Imatinib, Sunitinib, Regorafenib. So the advent of Blue 285 or Ripretinib has really given a therapeutic options for patients with PDGF, FAR, alpha, D842V mutant GIST. And in the FAR curve, you can see that not only did the tumor shrink, but measurement of circulating tumor DNA within the blood also decreased rapidly to really an undetectable level. So this is cumulative data that was presented at ASCO, and what this shows, you see a bunch of blue bars. These blue bars, when they go down, that means the tumor is decreasing in size. When the bar goes up, that means the tumor is increasing in size. And so the only patient who had a tumor increase in size was patient with the gray bar who did not have a D842V mutation. It was a different mutation called 659. So that one was resistant, but every single other patient's tumor decreased in size, and they all had D842V mutation, and they all decreased to some degree on Ripretinib. So it's a highly active drug for this mutation that's resistant to all other therapies. The response rate is in the 90% range, if not higher, and patients do well for a very long time. So there's another new agent that's in study, and it's an agent called Ripretinib. It's in phase 3 registration studies, and these studies are looking at its activity in second-line therapy after Imatinib, fourth-line therapy after Regorafenib. And what's been discovered is that it's highly active in situations where a patient's GIST is resistant to other known kinase inhibitors. And that's because Ripretinib was again designed specifically for GIST patients, specifically to target KIT and PDGF receptor, and specifically designed to bind to a different location on the receptor than where Imatinib binds or where the resistant mutations occur in an area called the switch pocket. So it's really designed to take on any type of resistance mutations. And you can see on this slide with the red bar, the patient's tumor has really shrunk fairly substantially on therapy just after 2 cycles. So this is 8 weeks of treatment, and we're seeing a great response in a patient whose tumor was resistant to everything else. So I'll say a few words about this more rare type of event. This is called a translocation, where a gene called ETV6 is fused with a gene called NTRK3, and this happens in GIST. It's very rare, but it's important to know and recognize because there's an effective therapy for it called larotrectinib. And larotrectinib, you can see on the PET scan at the top, these big dark tumors that got a lot smaller over time as you go from left to right. So let's talk a little bit more about resistance mutations. Resistance mutations occur basically in 2 locations, exon 13 or exon 17. And so if you look at this table, this is my interpretation of the available data to support the activity of kinase inhibitors in the setting of primary and secondary mutations. On the table, you'll see in the first column, Imatinib, Sunitinib, Regorafenib listed down the side. And then the first 3 columns after that are the primary mutations, which are largely in exon 9 and 11. And then farther out to the right, you'll see the resistance mutations in 13, 14, 17, 18. Now, in this table I made, green means the drug is effective, red means it's ineffective. And so I'm just going to make a couple of simple points that all of these drugs are effective against the primary mutation, exon 11, exon 9. They all have activity there, but when resistance mutations occur, things change. Namely, Imatinib is resistant to all of these medications. And so it's when these resistance mutations occur, Imatinib is just not effective anymore, and we have to try a different medicine. Well, as it turns out, when the resistance mutation is in 13 or 14, Sunitinib is green, so it's quite effective in that situation. Whereas the other agents like Regorafenib, etc., are not so active in the 13-14 area. Conversely, if you keep going out to the right, Sunitinib is not very effective at exon 17 or 18 resistance mutation. Whereas if you go down the table, you'll see Regorafenib has some activity, the Plexicon drug, Ponatinib, Avapritinib, and Ripretinib, DCC 2618, have activity at the 17 and 18 location. So now we're really starting to learn how to tailor drug therapy to optimize and deliver the best therapy based on data such as these mutational data. Well, I apologize, my screen's not advancing.
Does it maybe help to restart the presentation?
Yeah, well, it's not letting me do anything. It's kind of frozen.
Okay.
I don't think I had many more slides left. That's really the summary that I had was, I think that's pretty close to the end of the presentation. So I can just really summarize by saying that for patients with primary GIST that has not spread anywhere, surgery is really the mainstay of therapy, and surgical approach should follow surgical principles. I recommend that a biopsy be performed before surgery so that the diagnosis of GIST is known so that the operation can be planned appropriately. Again, I'm not a surgeon, but that's what seems to make sense to me as a medical oncologist. Taking Imatinib after surgery or before surgery is an individualized decision and a discussion to have with your treating physician. There's certainly guidelines regarding the size of the tumor and the aggressiveness of the tumor in terms of its mitotic rate. Patients, we have a number of effective therapies that are available: Imatinib, Sunitinib, Regorafenib. They all have activity. They all can help GIST patients. We generally use them in that order. We also have a couple of new agents such as Avapritinib and Ripretinib, and these agents are being studied in second-line therapy, third-line therapy, fourth-line and beyond therapies. And these agents are clearly having activity. Whether or not they're going to be better than the standard, time will tell. But if you are a GIST patient, I encourage you to participate in any of these trials that you can, because it does give you access to medications that are not otherwise available yet that are clearly effective. And then towards the future, I believe that circulating tumor DNA assessment in patients and assessing response, in assessing recurrence, and helping us choose which second, third, fourth line therapy are optimal for a patient based on our knowledge of circulating tumor DNA based assessment of resistance mutations. And so in conclusion, we've come a long way with GIST. We have a number of active therapies. We have a number of newer therapies on the horizon. Hopefully, we will continue to develop newer treatments and newer ways to detect it earlier, better surgeries, and hopefully we will one day, through all of our research, find a cure. So again, I'd like to end by thanking everybody for taking time out of their afternoon, their evening, their morning, whatever your time zone is. And I'd like to I'd be happy to answer any questions.
So thank you very much, Dr. Trent, for giving this great and very clear overview of what's happening in GIST at the moment. And I think there are some very exciting things coming up. I would like to open the questions and answers session. We do have a question on the chat, which I just start with. So the question is, if there are multiple lesions in the liver, and each tumor has a different mutation, then how is it handled, as one drug might not work for all of them?
This is a good point. And so, so you have a couple of options. There's several options there. And so one option is, if it's only one lesion or limited number of lesions, you could resect them, or you could biopsy them and know what the mutation is that way. Another option, if you have access to circulating tumor DNA, you can do that test, and that test will tell you, will give you a quantitative assessment of what the most common resistance mutation is. For instance, it may be all exon 13. There may be a tiny bit of 17, but maybe not much, or maybe none. And then that would steer you towards perhaps sunitinib. That might be, if that's available, that might be one opportunity. And then the other way to do it is simply, if the patient's imatinib resistant, start with sunitinib. Just keep a close eye on things and look at all of the nodules that are in the liver and figure out whether or not they're all responding, whether some are responding, or whether none are responding. If you treat with sunitinib and let's say most of them are responding to it, but there's one or two that are not, they might in fact have a different mutation, such as exon 17. And that could be an opportunity to either ablate or embolize or resect those that have the mutation that's resistant to sunitinib.
Right. Thank you very much for this answer. I have a couple of more questions coming up, but I also would like to encourage you, our participants, to speak up if you don't want to post your question on the chat. But I'm just gonna keep on reading. So you mentioned the measurement of circulating tumor DNA at some point. Is that well established for any form of GIST?
No, it's really something that's being studied in clinical trials. It is available in some parts of the world, but it's not available everywhere. In the U.S., not all insurance companies will cover it, so we certainly can't do it in all GIST patients. It's not been validated in a prospective clinical trial, but that's what the next step really should be, is to perform a prospective clinical trial to see if that assay impacts outcomes.
We hope for that. That'd be great. Okay. Can you comment on immunotherapy and GIST?
Very good question. And so immunotherapy and GIST. So there's not any clear home runs yet, but there's lots of interest. About 10 years ago, one of my colleagues, Lei Chen, and I did a clinical trial where we gave GIST patients imatinib plus a medicine called interferon that stimulates the immune system. It's important because we know that there are immune cells within a GIST that could be turned on by interferon. And in fact, we did see some potential for increased activity, but it was not a home run, but there were some hints of activity. And then later we performed this trial, axitinib plus pembrolizumab, in patients with refractory GIST resistant to all known kinases. we only treated a handful of GIST patients because it was for all different types of sarcomas, but we didn't find any activity of pembrolizumab as a single agent with axitinib. And so there's another trial that's looking at nivolumab plus ipilimumab in patients with metastatic GIST that are refractory to other kinases. This has not been published yet, but I have heard there have been a patient or two that have responded to this therapy. So perhaps these combinations of immunotherapy are going to be what's required to help GIST patients.
Okay, you just have to wait, I think so. I have a double question. So, what is the most common secondary mutation of an exon 9 primary mutation? And which experience do you have regarding the effectiveness of Ripretinib BCC 2618 after progress under Imatinib?
Yeah, so for exon 9 patients, we sometimes see resistance in the absence of secondary mutations, which may have to do with pumps that pump out Imatinib or other mechanisms of transporter mechanisms for which we don't fully understand yet. But with exon 9 mutant GIST patients on Imatinib, most commonly I've seen exon 13, but you can also see exon 17 secondary mutations. Both of them can occur. If it's an exon 17 secondary mutation, Avapritinib and DCC 2618 or Ripretinib should be effective at exon 17 mutations. At exon 13, we're not quite sure yet. So there's a lot of that's an active question in clinical trials. So we don't really fully know all that information. Hopefully, the ongoing phase 3 trials will accrue patients, and we can answer that question.
Okay, another one where we have to wait. I have another one. Okay, looking at the differential sensitivity chart, DCC 2618 is mostly green. Anecdotally, I've seen many patients fail it quite quickly. I'm an exon 9, so I've been following exon 9 experiences closely. Does DCC 2618 seem to be working better for some mutations than others?
Again, that's hard to tell. This is a chart that's based on some of my experience. It's based on in vitro data in systems that aren't necessarily even GIST. So this is kind of looking towards the future, but it's the way that I see it right now. And other people, see it similarly, such as Cesar Serrano in Barcelona, and Mike Heinrich in Portland. But I think that still has a lot of work to do to be fully validated, and we have to be careful to, not make broad generalities based on small numbers of patients. So I think that this will evolve over time, and hopefully we'll have some new drugs in the far left column. And, I think the phase 3 studies, again, will tell us more.
Okay. Thank you very much. Those were the questions I had on the chat. Are there any more questions from our participants? Please feel free to speak up now. Anyone? Now's the time.
I have a question. From the last slide, the ponatinib looks as effective as DCC 2618. What is ponatinib? Or is it not widely used?
Yeah. Ponatinib has a trade name in the U.S., Iclusig, and it's FDA approved in the U.S. for leukemia. it has been studied in a clinical trial looking at just patients, a small phase 2 study. I don't believe it's been published yet, but it does have seemingly interesting activity at exon 17 and 18, particularly in those areas of GIST.
I have some more questions coming up on the chat. Can you tell us if DCC 2618 and Ripretinib will be available without being on a study?
We don't really know whether the studies are going to be even positive. So presuming that the studies are completed and that they show activity, they will have to be presented to the FDA, and the FDA will have to make a decision, which could easily take at least an additional year. So we're still a ways out.
Okay. Another question. When you say average life expectancy is 7 years, is that for anyone who has been diagnosed, or is that in the metastatic setting?
That's in the metastatic setting. I think if it's not metastatic, many patients should be cured. If it's not metastatic, not everybody, but many patients are certainly cured. In the metastatic setting, I just use 7 years as an example from a recent publication, in contrast to the 9 months that the patients had so many years ago before the discovery of these tyrosine kinase inhibitors. And so I suspect the number is actually longer than 7 years. We all have patients that we see or that we know that have been on these medicines for 15, 16 years. So I think that as we continue to improve care, as we continue to improve awareness, as we work together with patient advocacy groups, we're only going to keep making these survival numbers longer and longer.
I agree. I would also add to, have patients treated by experts, but I think your presentation clearly shows that it's not very trivial to treat GIST, especially when it comes to a progression, and should be treated in an expert center. Do you agree?
Oh, yeah, I agree 100%.
Okay. We have another question coming up from the chat. Are there any new trials on the horizons, probably in a year or two?
Well, there's a few trials that are being proposed. There's some immunotherapy trials that are ongoing that are also being proposed. There's some that are ongoing. There's a trial looking at Imatinib plus other drugs, such as other kinase inhibitors, such as MEK inhibitor. So yeah, I think there's going to be lots of exciting trials in the pipeline, including I'm very happy and look forward to seeing more immunotherapy trials so that we can really figure out the immunosuppression that occurs within GIST. But yeah, there's lots of trials in the pipeline. And I think once Avapritinib and Ripretinib are approved, then they will look to build on those approvals with additional trials.
That sounds great. Keep our fingers crossed. So maybe we have a couple of more minutes for answering questions, say 5 minutes. Is there anybody else who would like a question, to ask a question? Anyone? I have another one on the chat. How can I be sure after a biopsy of one tumor about the mutation when I have several tumors? Can I have different mutations in different tumors?
So that's a very good question. So generally for most GIST patients, we find a primary mutation. That primary mutation is the same in all tumors in the body, and it stays the same in all tumors in the body, and it never changes. and that is KIT exon 11, KIT exon 9, PDGFR, SDH, RAF, RAS, NF1. Those types of mutations are the primary mutation, and they stay the same, and they're in every single tumor cell in the body. Now, when a tumor becomes resistant to imatinib, you can have resistant clones emerge, resistant nodules emerge, and these generally have either exon 13 or exon 17, one of the two. It's usually one of the two. And if there's multiple resistant clones, resistant nodules, it's still usually one, it's usually one or the other. If the patient has had several lines of therapy, 3-4 lines of therapy, then that's when we kind of start seeing some unusual resistant patterns where you might see one nodule with exon 13 and a separate nodule with exon 17. But it's usually not the case.
Okay. Any more questions?
Yes, I have one more question. I saw a recent report about an MEK inhibitor plus a phenothiazine has an effect on killing the yeast cells grown in the lab. What do you think about that?
What type of inhibitor?
MEK?
Oh yeah, MEK inhibitor. It has shown some activity in the lab, and there is a clinical trial that Ping Chi performed looking at imatinib plus the MEK inhibitor. I don't think it's been published yet.
Do you know what is the result of that trial?
Not yet, no.
Thank you.
So I think one last question from the chat. What are the most common side effects you observe in your patients with high-dose imatinib? Do you recommend any additional intervention?
Yeah, high-dose imatinib is pretty hard to tolerate. The most common side effects are fatigue and swelling. And so there are other side effects also, such as diarrhea, skin rash. And it really depends on the side effect, but we try to manage these very aggressively. If it's diarrhea, we use Imodium. If Imodium doesn't control it, there's another agent called Lamotrigine that might control it. And then if that's still not controlling it, then we resort to an older medicine called paregoric or tincture of opium that's almost always effective. If edema is the problem, a patient might need diuretic, such as furosemide or hydrochlorothiazide. If the problem is rash, there might need to be a topical application of a corticosteroid. So it really depends on the specific side effects in order to determine what is the best treatment.
Okay, thank you very much. I have to admit I overlooked one chat question. I would still ask that one, and then we close the meeting if that's okay for you.
Yeah, sure.
The question is, I'm taking imatinib ever since a recurrent, no, I missed the first part of the question, sorry. It's a two-part question. I got my exon 11 diagnosis in 2013, and the tumor was resected after imatinib treatment in 2015. I am taking imatinib ever since, as the recurrence risk is high. In 2017, two desmoids have been detected and resected. Do you have any explanation for the occurrence of desmoids under imatinib?
Yeah, so I don't have a great I don't have a great explanation, but that's a well-recognized syndrome. That's why I personally have a very low threshold for biopsying something that I see as maybe not necessarily recurrent GIST. And so in doing that, we published a series a few years ago of 28 patients that all had a GIST and all had a desmoid tumor. There didn't seem to be anything in common. For instance, the desmoid tumor patients didn't have KIT mutation, and the GIST patients didn't have a beta-catenin desmoid mutation. So there must be some underlying genetic susceptibility. It didn't seem to be due to Imatinib. It happened before Imatinib in many patients. So Imatinib doesn't cause it, but there must be some underlying susceptibility to acquiring a GIST and a desmoid tumor. If you want to hear more about it or learn more about it, you could go to our publication by first author Dumont, Henri Dumont, D-U-M-O-N-T. So I call it Dumont syndrome since he's the first person to describe it. And but it does occur. What we have to do is just treat the desmoid tumor like a desmoid tumor, treat the GIST like a GIST, and give the patient the best shot at being cured from both.
So, thank you very much. I think we're going to close the session tonight. John, thank you very much for taking the time, for giving us this presentation, and for taking the time to answer all the questions. I thank the participants for being so active and asking all the questions. As I said at the beginning, we did record the session, and we will put it online on our website within the next couple of days. Just have a look, and yeah, thank you very much, and have a good evening, afternoon, or morning, whenever, whatever time it is at your place. Thank you very much.
Thank you, Catherine. Thank you, SPAEN, and thank you, everybody. Have a great day.
Thank you, John. Goodbye.
Bye.